Welcome to the Medical Home webinar series. This is the third webinar in the series of 6. Today's webinar will be presented by Ruth Gubernick, Consultant and Quality Improvement Advisor. Before we begin, few announcements. This webinar series is supported by the Health Resources and Services Administration of the U.S. Department of Health and Human Services under Genetic Services Project Grant to Health Research Inc. and NIMAC, the New York Mid-Atlantic Consortium for Genetics and Newborn Screening Services. This activity has been approved for AMA PRA Category 1 credit, that is reciprocity credit for allied health professionals, nurse practitioners, nurses, and physician assistants. The required CME accreditation is included in the slides and handouts. Instructions on how to obtain a CME certificate of credit is also included in the attached handout. These handouts can be accessed through the control panel on your screen. This live webinar will take approximately 1 hour and will be recorded. The recording will be available at a later date. As soon as the webinar concludes, you will be asked to complete an evaluation survey. Please take a few minutes to provide your feedback. Your input will help us in planning future activities. Participants claiming CME credit, please access or use the handout that reads How to Obtain CME Credit, Webinar 3. The instructions are provided in that handout to complete the evaluation survey and claim your CME credit. All other participants, please complete the evaluation survey that follows after the webinar. There are no conflict of interest disclosures or off-label discussion to announce for this webinar. At this point, we would like to acknowledge our colleagues. We thank HRSA for their support. We thank all speakers and participants of the Medical Home webinar series for their contribution and participation in this series. Should you choose to ask questions or comment, please use the question box in the webinar tool panel to submit your questions and or your comments. We will cover as many questions and comments as time permits. Responses to the remaining ones will be emailed later to all attendees of this webinar. On that note, we are pleased to invite Ruth Gubernick to present today's webinar, Medical Home Building on Improvement Model. We'll begin with a brief introduction. Ruth, thank you.
Thank you, Kunal. Good afternoon, good evening, good morning to any of you who are not on the West Coast, on the East Coast, sorry. I'm an independent consultant, and I've been a quality improvement advisor and coach for several medical home initiatives, including ones that have to do with newborn screening and genetics and primary care. And those have been sponsored nationally by the American Academy of Pediatrics. And I've also done quality improvement work around medical home in New Jersey in initiatives sponsored by the New Jersey chapter of the AAP and the Statewide Parent Advocacy Network of New Jersey, known as SPAN. So for the next hour, I'd like to focus on these 3 initiative objectives. I'm going to discuss the ways to use the PDSA, the Plan, Do, Study, Act cycles, as a quality improvement strategy to help you accelerate change and sustain improvements. And I will spend a few minutes going over the model for improvement, so those of you who are not familiar with it, don't be concerned. Also going to talk about how to assess the application of technology in implementing your medical home, and specifically in care coordination practices. And the third objective that I'll focus on will be to discuss some examples of innovative care coordination models so that we can think about partnerships and collaborations across multiple models, care models and systems within your medical home neighborhood. Next slide, please. So just remember, this is the first law of improvement. Every system is perfectly designed to achieve exactly the results it gets. This was stated by someone I think very highly of, Don Berwick, who really points out that this isn't about the people not doing a good job or doing what's expected, but it's about the system that's designed. So this is an opportunity to look at system improvement. Next slide, please. And why do we even need to have a quality improvement strategy? Well, this model for improvement in particular really provides a good framework. It shows us how we're going to get where we are and where we want to be, what our goals are. And it really uses measurement to show us about the journey, where we are today, and lets us know when we get to our destination or our goal. Next slide, please. I always like to point out that when you're doing quality improvement work, it really is a team sport. It's about using the whole multidisciplinary team within your practice to do this work, and it should be at various levels within your organization. It's really very important to have the buy-in from a high-level clinical leader who may not be involved in the day-to-day work, but will allow you to do the work that you need to do. Technical expertise is essential. It can be in-house technical expertise that you have, or being able to involve your vendor, your EHR or your registry vendor as a member of your committee for this work that you're doing. Day-to-day leadership, whether it's physician leadership, nurse management leadership at various levels are essential. So you may have a core team, but everybody, as you can see, is going to be part of this overall team. Your administrative staff from your front door to your back door. Parent partners, and not necessarily just one, but it can be more than one. And if you're working on a grant-sponsored project, to also make sure that your project sponsor is involved as well. Next slide, please. So I'm sure that this looks very, very familiar to most, if not all of you, and this is the model for improvement, and it answers the three fundamental questions of quality improvement. The aims, which answer the question, what are we trying to accomplish? Measures that will answer, how will we know that a change is an improvement? And the ideas and strategies and best practices, everything that comes together with the PDSA cycle that are going to help you identify what changes can we make that will result in improvement. Next slide, please. So it starts with, as you may know, a SMART aim. And it's very important that your aim have these characteristics, that it is SMART, it's specific, so that everybody can understand what your goal is, and that you have measurable goals, that you say you're going to achieve 90% of your patients are going to have a care plan, or that you have asthma control test will be done on at least 95% of your patients who have a diagnosis of asthma. It's actionable. You know who's going to do it, what's being done, when, and where. And you have to make sure that it's an achievable goal, that it can be a stretch. You may want to do incremental goals if you're at a very low level and move it up along the way. It needs to be something that's very relevant to the stakeholders in the organization, and that can be the stakeholders being the patients and families, or it can also include the physicians and staff and the larger organization. And one of the things that I often don't see as part of aim statements, or that it needs to be timely. You need to identify what's your specific time frame, that you're going to do it by when, by next month, by December 31st. Make sure that you time frame your aims. Next slide, please. So the second question has to do with how will we know that a change is an improvement, and this is where measurement comes in. And just to remind you that this is quality improvement, it's not research that we're doing here, and so you need to just build enough measurement in to use on a day-to-day basis as part of your daily work. And it's going to be because you're going to be testing very small samples over time, so it can be data that represents the next patient that you see that you have done something differently with, and you measure that one patient. Or it may be the number of patients that you saw with complex medical needs during this morning's that you're going to be able to come together and identify how you did as part of your PDSA cycle. And again, I want to point out the importance of qualitative data as well as quantitative data. The qualitative data, if you have for the first time, maybe you're sharing a medical summary with a family and you've asked them to participate in the shared decision making of some aspects of that care. At the end of that visit, if you said to the parent, you know, this is the first time we've done this. What did you think of this? How do you feel about getting this summary or this comprehensive care plan? Parents will be very happy to give you feedback. And it doesn't have to be a formal survey. It can be, certainly. But even being able to get feedback on an informal basis is very important. And also to be able to get that same type of informal qualitative data back from your staff to be able to say how that may have impacted their work is really important as part of this process. Next slide, please. The other part of measurement is to be able to use something like a run chart. Here you can see that this practice team, this collaborative, which is made up of several practices, you can see that where they started at the beginning, their baseline, and where they finished after their fourth cycle in their action period. And it was a pretty steady increase over time. Now on the next slide, you can see that for an initiative where they were looking at whether or not their patients with food allergies had an emergency plan as part of their care, and that was a little more difficult for these practices. It bounced around a little more, and it may be very helpful if these are also annotated and you look at why things may have gotten better, what was the reason that things took a dive during a certain cycle, and to be able to understand what's working and what's not. And being able to track the changes over time like this are really an important part of this quality improvement model. Next slide, please. So the third piece of this is what change can we make that will result in improvement? And this is where you come up with your change, the concepts. It may be a toolkit that you're using or a change package. You've heard that name, where there are resources and there are tools, and you can take these and identify how to use them or adapt them for your unique environment. And doing that, use the Plan, Do, Study, Act cycle. On the next slide, I like this slide because it reminds you of all the different pieces of the PDSA cycle, and I want to just emphasize the need to really put some time into the plan, because you need to include your aim or your objective, and what questions you may have. What else would you have to do to be able to actually carry out this cycle? Are there any training? Is there a training that needs to happen for staff? Do you need to make any changes to your EHR or a paper form that you're using before you can actually carry out this cycle? Predict how well you think you're going to do. If you plan to carry out a cycle during your morning session tomorrow, and you want to use the ask parents what their top 3 concerns are during the visit, and you're going to you think that you may capture this for each of the patients that you see, and so predict, yeah, that's the case, I'm going to do this for everybody. But then at the end of the morning, look and see how many of those families did you forget to actually either collect that information or ask them when they were being roomed, if that's what you had planned to do, what their top 3 concerns were as part of that visit. So predictions are very important because they help you evaluate how you've done. And then plan to carry out the cycle. Who's going to do it? what's going to happen, where's it going to happen, and when. Then you're going to just do it. Carry out the plan. Don't worry, this does not have to be perfect. You don't want it to be exact. Don't be afraid of just coming up with one idea, but then after you carry it out, it's really important to study it. Complete the analysis if you collected some data on how many of the patients actually had. Parents were asked for their concerns prior at the beginning of their visit. Compare the data to what your predictions were, and then summarize this. And as I said, this is a team sport, so you may do this as part of a huddle at the end of the morning. This is not just for the physician to be doing. This is for the whole team that's involved in the actual PDSA cycle to come together and summarize not only what happened, but what you learned. This is about learning. And then acting, how did it go? Do you want to make changes to the next cycle? Did it work well? Did you find that it really was a total, disaster? Not what you planned initially didn't work at all, and that's okay. You can learn a lot from that failure. And then what changes you're going to make so you can do your next cycle. Next slide, please. So this is about sequential building of knowledge, and that's why you see this ramp up. You start with your theories and hunches. You're going to use your evidence and your data, and then move towards the point where you feel that there's a breakthrough in the results. You've made an improvement, and that you then want to implement the change. This is all about testing under a wide variety of conditions, sequential tests. And you're not going to just go to implementation until you know that something is working and that it's an improvement. Next slide, please. And you can do it where you can break into groups within your practice, especially if you're a large practice, and work on simultaneous cycles with different. You may have an overall aim, but then each cycle has an individual aim, whether it's about planning comprehensive. In this case, we're talking about comprehensive asthma care. There may be also a team working on improving the care for their patients with food allergies. That may be focusing on things to help create more family-centered care. It may be using an assessment to collect information about cultural beliefs and practices within your patient population, so that this can happen where you have multiple cycles going on at once. Next slide, please. The other thing to remember, and you'll see that as we do this, that the early tests can be very simple. You're going to then test under a wide variety of conditions. If you get residents and medical students in your practice, you may find that you get different outcomes based on whether the residents are there. If you're also working with the medical students, what happens during the summer when all of a sudden a lot of staff are out on vacations, or physicians, and you're shorthanded? How can you continue to do the quality work that you have been starting to implement under those conditions? And each time you're going to learn from what you are testing to be able to predict and prevent failures. Next slide, please. Because these are small tests of change. They're happening on a very temporary basis, and as I said, on a small basis, and the idea is to learn from that, because they can have a very important impact on the work you're doing. Next slide. This is an important slide, because when I talk to practice teams, right away they want to test a change for a month. So I encourage them, break it down to a week, maybe to a day, maybe down to just the next session that you have, where you're going to see your patients who are coming in for care. It may be the next 2 patients with special needs. So this is about really doing very small tests of change, and I can't emphasize that enough. Next slide, please. Because these changes aren't meant to be permanent, when a practice says to me that they have an idea for a new form that they want to share with families, if they say, oh, we're going to print out 500 of them and we're going to start using them on Monday, that's not a test of change. The idea is to use one or two, just because you're also going to ask that family, what did you think about this form that we're using? Did it get to the questions that we needed to ask you? Did you understand the questions? Because you may change that 5 times where you turned that form from a task to a test when you're getting that type of feedback and you're only using it for a few people to see that impact, so that you're going to have less risk in the improvement work that you're doing until you get to the point where you know that the new way that you're doing it is actually better. Next slide, please. So I encourage you to do PDSA cycles on a very small basis. You don't need consensus before you do that. Just test something you haven't done before. You're going to replicate the changes that have been made elsewhere. Please don't feel that you have to come up with your own ideas. You can borrow or steal shamelessly from another practice who may be doing something. You say, wow, we can do that too. Pick changes that you feel are feasible to try, and make sure that you don't get bogged down in technical problems. You may want to do it. Don't make large changes to your electronic health record. Initially, make sure that you've got something right before you add the field if you need to for documentation, and make sure that you take time to reflect about the work, the tests that you've done, because as I said, there's a lot to be learned from success and failure. Next slide, please. Here's an example of a PDSA worksheet that will allow you to be able to walk through how to establish your aim and plan a PDSA, and then document what you did and study it and act. The idea, though, here is people say, oh, we don't have the time to do all this and put it all in writing. I would really suggest at least test doing this a few times initially. You may find that it really works well for you, but really the most important part is that you're coming together as a team and that you're talking to each other and communicating. So again, these forms, creating this worksheet or doing it doesn't have to be perfect. It can be notes that you jot down, but it really will help you in the process of learning about that, doing this QI work and the PDSA cycles that you're testing. Next slide, please. Because those teams that really come together as a team and meet and people have assigned responsibilities, and that you test small tests of change, and you've engaged your leaders at the various levels of your organization, and you've also thought about how you want to use your technology, whether it's the decision support in your EMR or how you can use registries, which we'll talk about in a minute. And as I said, teams that get results, they also use best practices and tools and resources, and also the ideas that they have, but also strategies that are evidence-based and that other teams have learned from as well. Next slide, please. Because the practices that really hold those gains, which means that long-term they've been sustained, they continue to use their data and use run charts. They come together and report what they've done, and they're accountable to each other, and they celebrate their successes, whether it's now an agenda item on your monthly or quarterly meeting, and that you continue to have that leadership support and share your learnings with your leadership, meeting often enough to be able to make it useful to you as a team, again with key responsibilities assigned, and trainings done so that people feel that they are comfortable and confident with the work that they're doing, and written policies established so that regardless may come and go in the practice, there's and also training and orientation for new employees. That you may want to use checklists and make sure that the processes that you're doing are So we all know that there are going to be changes in your organization, so expect them and be prepared for them. Next.
Ruth, if I have a couple sentences, could you please repeat that for us?
Sure. So the practice teams that have reported that they actually are able to hold their gains, this list here is very important. Make sure that you're meeting your continuous run charts to celebrate your successes. Make sure that people are assigned to the key tasks and that there are, as I said, written policies, and that people are trained and oriented so that if you all leave tomorrow, that the changes and improvements that are part of your standard of care have been, do not go away with you, that they continue to be transformed and used in the practice. And know that, expect change in conditions and be prepared for them. Next slide, please. So now I'd like to just focus on the medical home model, and specifically for this webinar on providing coordinated care for your patients and families. Next slide, please. And specifically, how to use technology to help improve care coordination practices. And this is about using registries. So if you're not using a patient registry yet in your practice, I hope you'll pay attention to the next several slides, because they really do show that they can improve and streamline the clinical care processes for your patients, especially those with more complex and higher needs. It allows you to do a better job with documentation of your services. You can collect your data so for clinical benefit, and it also can collect data you can use for administrative benefits. You can use your registry for tracking and reporting the performance if you're doing a quality improvement project, and also to be able to track and report your adherence to guidelines for external entities, such as if you've been participating in meaningful use or a performance improvement initiative with a health plan, or other such organizations. Next slide, please. So the use of the registry really is to be able to help you with population management. And it may be your care coordinator or somebody who is also in the role of a care coordinator, even if that's in addition to other roles that they're playing, to be able to really be proactive about the care for chronic conditions. It may be looking at who are your patients with asthma, with a diagnosis of asthma, who need to be the first ones up to receive flu shots at the beginning of flu season. It may be those patients who are, your patients who are preemies, and you need to make sure that there is added attention to their well visits and the care that they're getting. It also helps you with that planned care for different populations of patients. If you have patients who are more complex, to know that that's a patient you need to schedule a longer visit. A 15-minute visit isn't going to be appropriate. To make sure that you've allotted enough. To be able to make sure that the pre-visit contacts that you may need have been taken care of before that family comes in for their next appointment. And to be able to alert staff and providers of special needs. If you know that this is a patient who is in a wheelchair and you know that they need one of your a certain exam room when they come in for the visit, to make sure that that's noted in a registry so that you can make sure that that happens. It also is so useful for referral tracking and to be able to follow up on those care transitions and co-management with specialists. You'll be able to track your referrals to specialists, and then knowing that did I actually get the report back, so that you don't have to chase it before that patient comes back for that next visit, but it's already there and has been reviewed. If you refer to family to a community-based organization, to be able to follow up and make sure that they actually got there, or that to be able to ask that family then, was that community organization useful? Was it helpful to you? Next slide, please. But the question is always, how can we implement a patient registry? So this in itself is an opportunity for PDSA cycles. The first thing you need to do is identify that there's someone who's going to be your care coordinator or registry champion to be able to track the care coordination aspects that you want for a certain population of patients. And as I said, meet as a team. You may want to just start with one population of patients. It may be just your patients with asthma. It may be a smaller group. It may be just your patients who have a diagnosis of epilepsy. It may be your patients with food allergies. This can be, you can identify who those patients are using diagnostic codes. It may be staff and MD recall, and coming together as a team and saying, well, what do we do now in our practice when we have a patient with asthma who comes in? And to be able to flow chart that process and understand who's involved, where does that care coordination happen? That's all part of this process as well. And then to be able to identify your data fields that you want initially. Do we want to be able to, we need to identify who is the patient. We want to know how old they are. We want to know what their diagnosis is. We want to know certain aspects of whether or not they go to a specialist. Sorry about that. I thought that was off. Do they, just to be able to point out to you that this may be as low tech as using an Excel spreadsheet. You may have access to an EHR within your registry within your EHR as a function, but it doesn't have to be high tech. It doesn't have to be within your EHR, but I would say ask your EHR vendor, because you may find that there's actually there's registry functionality within your EHR that you don't yet know about. And this can be the opportunity to use that. It may be a report that you can generate. But as I said, Excel spreadsheet is a great way to start. Could be an Access database, but that's a lot more complicated. Next slide, please. So let's talk about how to do this care coordination outside of the walls of your medical home. So you may have now established or at least started a patient population, a populated registry for a certain one or more patient populations. And now you need to be able to think about how can you connect with those other partners who are caring for my patients who have different diagnoses. And I really like this, this graphic because it just shows all of the different people that are involved with the in the medical neighborhood, and it really does take a village. Next slide, please. So think about your medical home coordination. Ask yourselves, how can we facilitate increased partnerships and communication across our medical home neighborhood? How can we facilitate seamless and timely transitions of care? So let's talk a little bit more about some of those partners that you can look to and you can develop or even enhance your relationships with in the coming months. Next slide, please. So co-management may be with specialists. This really is about focusing on enhanced communication. If you're a primary care physician or practice, think about the referrals that you're submitting to the specialists for a child that you're referring. Making sure that the information that will be useful to the specialist is sent maybe with the patient or even electronically, even better by fax or through a portal to that specialist, so that they have what they need before that family comes to see them. About the diagnosis, about any tests that you have done, any other medications that the patient may be on, complete information that will be helpful. And if you have any medical comprehensive care plans that you've developed, in return to be able to know that you get that information that you need back from the specialist about treatment plans that include medications and other things. How can you do that? What's the best way to do that? Well, it really is an opportunity to either develop or enhance that relationship. You may want to have a conversation. You may want to invite a specialist who you refer a lot of your families to into your practice to do a lunchtime talk about the type of care that's given to the children who have a certain diagnosis, and about those evidence-based guidelines, so that you can learn more about them, and they would be happy to answer any of your questions. That will help support the medical management between your practice and the specialty care practice, and to make sure that you both are in agreement with what you need from each other. It will allow for facilitating that seamless transition of care between both types of organizations. And as part of that too, it would be wonderful to include families as part of those lunch talks, or to be able to get feedback about the experiences that the families have had, to be able to make sure that your your co-management with those specialists are working on an ongoing basis, and that you can close any loops. Next slide, please. Another member of your neighborhood, the emergency department, and the hospital or health systems. Again, this is an opportunity to enhance communications. You may want to start with one emergency department or hospital that's in your neighborhood, and be able to meet with them and discuss how you want to learn, how you want to them to be able to share information with you when they've seen one of your patients, either in the emergency room or because that patient has been admitted for care. I know practice who found that when they met with their emergency department, they found that the information of who was the child's primary care provider was not being collected in the ED. So they didn't have the ability then to be able to reach out to the primary care provider and share the information that was needed. Or it may be that once you know who the point of contact is, since you're the primary care or the specialty provider, that you establish a rapport with the ED and follow up to make sure that you have that information. It may be that you have access to the information, to the EHR, to be able to see which one of your patients may have been in this health system. Or you establish a way to get faxes within a reasonable amount of time, so that you can then coordinate your care, make sure that you see that patient back in your practice after they were in the ED or the hospital, to be able to check on their symptoms and their medications, to be able to review that treatment plan and make sure that the follow-up that you've done in your practice is in a timely fashion, hopefully within 48 hours to 7 days at the longest after that patient was in the ED or the hospital. All of this is an opportunity for improvement if you're not already doing this in your practice. So I hope you're taking notes and thinking about which one of these innovations you may want to test doing in the next week even. Next slide, please. So don't forget about your partnerships with the schools in your community, because the families really rely on schools to keep their children safe, and the families rely on you, of course, to provide that needed information to the schools to keep them safe. So it is, again, about being able to enhance that communication with the schools. So it's not just the parents who have to be the bearers of that information between you and the schools, but to be able to set up communication on an ongoing basis. Even if you may want to meet with members of the school, maybe the school nurse or a principal in your local school, so that you can establish a system to be able to to create that care coordination, and make sure that there's an understanding about the medications and that they feel comfortable and have trained personnel. You may go in and do education to teachers and staff on how to administer an EpiPen or epinephrine for the child with food allergies. You may want to even take families and do it as a tag team in a certain school. Or maybe there's an opportunity to be at the table even virtually for IEP meetings. And that again is an opportunity to coordinate care with your families and your schools. Next slide, please. Because it really does require open communications between the schools, between you and the families, and because you do have shared goals and responsibilities, and it's an opportunity, as I said, for ongoing family communication and participation in the decision making and those care plans that are needed for the schools as well. The next slide, please. So another very important aspect of your medical home neighborhood are your community partnerships. It's not just enough to create a list of resources that you identify that are in your community. It really is very important for you to know who they are and what resources they offer. So again, use it as an opportunity to invite them in and learn more about them. You may want to identify home visiting programs in your community and learn about what are their criteria for home visiting, so that you can make referrals for families that may really benefit from having a home visitor be part of their team, and that you can be able to work hand in hand with those home visitors who also are in the home and can share information back with you. The parent partners that you engage, the community health workers, they know the community. Also think about your local public health department. Invite them in for a lunch and learn. They can give you good information about organizations like the WIC program, about housing and pest management, what kind of a rodent problem or some other type of infestation, how can they make sure that they get the inspection and the fixes that they need, to learn about what kind of opportunities for utility assistance, especially this time of year in the winter, what's available and how to connect a family with those resources. So these partnerships, as well as your specialists, your emergency departments, your hospital and health systems, are all very, very important to be able to support the coordination of care for your families throughout your practice, but certainly especially who are in need of that care coordination. So next slide, please. So I'm going to leave you with some questions and strategies to consider as tests of change, maybe later in this week or maybe tomorrow. Think about and talk among yourselves about what are your current communication pathways that you've developed in your office. Maybe you do have some. Who do you have partnerships with currently? Or is there a specialist that you do have a good relationship with, but maybe there are some that you don't have as good a relationship or process with, and so that you may want to take what you're doing well, what's working well, and think about how to use it with another connection within your community. If you have a process or a partnership in particular that you'd like to either make for the first time or improve, that can be done using the PDSA cycle. If you are going to just implement change, you may find that it doesn't work well. Please take the time to test change on a very small basis with the next patient or the next one partner to be able to improve the partnerships with your members of your medical neighborhood, and also the care coordination with your families in need of that care. Next slide, please. So just to bring it all home, that we just talked about the ways to use a PDSA cycle, Plan Do Study Act cycle, as a strategy to be able to test change, make change more rapidly, and also to be able to sustain those improvements that you make. Talked a little about the use of registries to be able to manage populations of patients and how important that is to improving your medical home, and in particular your care coordination within your practice. And then being able to look at who are your partners within your neighborhood and how can you better collaborate with them to be able to help coordinate the care across multiple care systems for your patients and families within your medical home. Next slide, please. So here are some references for you about quality improvement in particular, and I just want to say thank you to Dr. Holder-Niles for her medical home neighborhood slides. They were really helpful. Again, I borrowed seamlessly because they really did a good job of telling the story. So thank you, Faye. Next slide. Any questions? I'm going to turn this over to Kunal to see what questions have been submitted. Thank you very much for your time and attention today and for the opportunity to talk with you. Here's my contact information. Please feel free to reach out to me if you have any needs. Kunal?
Thank you, Ruth. We have a first comment, and it's sort of a question. It says, can you comment on teams that have chosen to have family members as part of their team?
I can, and I can tell you that the experiences that have been reported and that I've seen firsthand by having parents and family members at the table as part of the quality improvement team have really been invaluable. Having that voice and that perspective is really essential. So if this is something that's new to you, I would suggest that you talk among yourselves within your practice, staff and physicians and everyone to identify, one or more patients. You know who the patients are who are good advocates for their children. They are the parents, the families that will maybe the first ones who will be interested in working with you and participating with you. It can also be an opportunity to even put a notice up in your waiting room and ask directly. Tell the parents, the families, that you're working on medical home improvement, and ask them to identify themselves if they're interested in being a member. You have to keep in mind too that they may not always be available at a time when you meet because they may be parents of young children or parents of children with complex needs, and so it would be important maybe to also think about how to engage them either before or during, virtually, maybe by phone, to have them join a meeting that you have, or to be able to get their feedback afterwards. Ideally, though, you really want to include them, as much as possible in real time. Think about maybe offering also an incentive, whether you can give them a gift card for their participation. I mean, you're all getting paid for this work that you're doing. It's nice, and they'll be happy to volunteer, but sometimes a little thank you like that really goes a long way, or to be able to offer them something towards childcare. Be creative. I have seen many times that one or two, starting with one or two parents or family members, then is what then can move you forward in the future towards creating a family council or parent committee to work with you. So those are just some that's ideas and food for thought. There are also some great resources. NicheQ had created some wonderful resources for how to engage families, and there are others as well. So if you contact me, I'll be glad to send you those links or those resources.
I see a few hands raised on the control panel. Quick request to all participants. Should you have any questions or comments, please use the question box to type in your questions and comments. Thank you. The next one is, how much should teams share with families, patients about the processes they are targeting for improvement? And a supplementary is what patients should expect, how the patient's role, responsibilities may change, etc.
I would definitely share widely with your patients and families with the work that you're doing. I think that I know from experience that they're going to they're not going to beat you up about if you share information. Sometimes that's a concern that if you know that you're not doing something well now, you don't want to let it be known that that's the case. Please don't be afraid of your patients and families. They will, if anything, really be able to make you feel good about all the things that you're doing well, and to be able to give you feedback about an opportunity about how to do something better. They'll be honest with you, and I would I would say that as I indicated, even to be able to, if you're testing one change, like the use of a pre-visit form, or you asked them to fill out a developmental screening on let's say, using the portal, make sure that you ask those who did it for their feedback about how it went, because they'll tell you, they may tell you, wow, that was great because I could do it at 1 o'clock in the morning. That worked for me. Or they could tell you, that the technology may not have worked as well as you thought it would. So don't be, that informal feedback from families. Ask it. Everybody can ask, but also use the information. Don't just ask and not do anything with the information. You can let the families know that you're working on improvement. They'll be happy about that. They won't think that, they don't think that they're going to say, oh, well, gee, maybe they're not as good as I think they are. You are all medical homes already. The fact that you care enough to become better medical homes is to be applauded. So, publicize that. Put your data out there as you're doing run charts. Families would love to see the work that you're doing. Get them involved if you're doing process flows or flow charts, because you may think it's going a certain way. Get the parent feedback too and say, that didn't happen that way. I never got that form, in the waiting room, or nobody asked me that question in the exam room. I remember one of the most early on, a provider, I asked a provider at a table, how to use screen for maternal depression, and the physician told me the questions that she asks to all new mothers, and the new mother who was at the table said, you didn't ask me any of those questions. And that was so important. She wasn't angry about it, she wasn't mean about it, but it just showed kind of the reason why it would be important to put a screening tool in place like the Edinburgh, for example, because then there's the opportunity for system improvement, and it's not just dependent on, you know, one person asking a few questions. Another question, Kunal?
Sure. The next one is, do you have examples on QI and care coordination in regard to SCH transition from PEDS to adult care?
There are some great resources available that you can use, you know, for with your QI. One in particular that I can think of is called Got Transition, a website, and there's another one as well that I'm drawing a blank on, but if you email me, I'll be happy to put you in touch. Also, I'm offering, you know, if you plan a test of change and you know, maybe it's the first time you're doing it, feel free to email it to me with your, you know, your worksheet, and I'll give you some feedback. In terms of transition of care to adult care, I remember a pediatrician who found that the most important thing was to identify who are the adult physicians in his community who would take his patients with special health care needs, you know, his more complex patients who needed to transition to adult care, and it was more difficult. And so he went to a meeting at the health system with the adult docs, and he was able to identify and start developing a relationship with those physicians and their practices, and identified 3 or 4, which was great to be able to help transition the families with children with complex needs who needed to go on to adult care.
We have many more questions, but I think we can take a couple more. The next one is, we have paid medical home parent partners working in practice as QI partners, as well family resource specialists in Maryland. We would be happy to share about the experience. So this person. So quick request, if you want to share any resources that can be shared as a handout or a link, please feel free to email it to me. You can reply to the email that you received with your reminder for the webinar, and we'll be happy to distribute it to everyone. I would also like to remind all participants that in this webinar series, we have a focused webinar on resources related to medical home for providers as well as parents and family members. It will be held in May, and the announcements and the webinar information were shared with everyone. So we look forward to your participation on that as well. The next question is, we are currently running 2 QI projects with incorporate parent partners assigned to pediatric PCP participants, assisting to connect parents, families to resources. This is the 2nd year of projects, and we've had great success. So thank you for that comment.
Great. Good job.
So one more comment. Families report that appointments with physicians seem rushed, quite likely due to the constraints of billing and medical insurance constraints. What can families' practices do to overcome these constraints? So that's a question, Ruth.
So what I would suggest is you may want to do a flow chart of your process and see where the bottlenecks are that may be causing those issues, and whether or not there need to be some changes to roles and responsibilities. Maybe there's someone else who can, do that, or there may be something either, it sounds like pre-visit type of, it sounds like it may be at the front desk that there, the front office where some of those bottlenecks may be. And to do that too, make sure that the staff who are involved in that process are the ones who are actively engaged, because they're often the ones who have the best suggestions about how to make it better.
And a supplementary to that was what is possible in the current environment.
Current environment meaning just the fact that you have to do this. Well, I mean that what's possible, you know, can be determined based on knowing how you're actually doing it within your practice, and maybe come up with an idea to test, because you know right now the environment, the overall environment of having to actually do for the payment purposes may not change, but the way you actually do it within your practice, you may find a better way to do it. And again, you know, engage your families as part of in that conversation as well. What specifically is it, or where is, you know, is the rush? You know, are they waiting a long time and then feeling that they're rushed? Are there things that other staff members can do rather than the physician, so that there's more time for the physician to focus on other parts of the visit? I mean, that's why I'm suggesting do a process flow and see where the bottlenecks are.
Great. I think I will take one more comment, Ruth, and then we can work offline to summarize the remaining questions and comments. So the last one is, we are Queens Sickle Cell Advocacy Network in New York, working with National Sickle Cell Disease Association on establishing a registry of people with sickle cell disease. So, okay.
That's great. There'll be, and so please, if you have a practice with patients who have sickle cell, then invite this organization in, or even if it's a webinar, and learn more about them and work hand in hand.
Great. On that note, please accept our gratitude, Ruth, for an excellent presentation. And a friendly reminder to all our participants, thank you for attending this webinar. Please take a few minutes to complete the survey after this webinar. And a quick reminder, participants claiming CME credits, please access the How to Obtain CME Credit handout to complete the evaluation form and claim your CME credit and certificate. Thank you, everybody, for your time, and we look forward to your participation in the subsequent webinars in this series.
Thank you. Thank you all. Have a good day.
Thanks, Ruth.